We have a few people in the house. My name is Shelley Keller. I'm a nurse practitioner at Mayo Clinic, and I've been asked by Anne to help moderate this session today. And first of all, I want to say it's our pleasure to welcome Dr. Craig Brown, from clinical clinical assistant professor of vascular surgery at the University of Michigan Medical School, as today's featured speaker for the Society of Vascular Nursing's discussion on venous thromboembolism, diagnosis and treatment. Dr. Brown is a highly accomplished vascular surgeon who practices at the University of Michigan Health Ann Arbor and the Ann Arbor Veterans Affairs healthcare system, where he cares for the full spectrum of vascular disease, including aortic and aneurysmal disease, along with mesenteric and cerebral occlusive disease, as well as vascular and hemodialysis access. Dr. Brown completed his medical degree at the University of Chicago Pritzker School of Medicine in 2016, followed by a general surgery residency and 2-year research fellowship at the University of Michigan, during which he earned his Master's of Health in Healthcare Research. And he subsequently completed his vascular surgery fellowship at the University of Michigan before joining the faculty at University of Michigan. His academic interests include surgical quality improvement, healthcare payment policy, and impact of system incentives on surgical care and outcomes. Areas that basically uniquely position him to offer insight into the complexities of modern vascular practice. Dr. Brown is also an active researcher, educator, contributor to peer-reviewed literature, and serving on multiple professional committees. His work spans topics highly relevant to patient care and vascular team collaboration, making him an exceptional voice on evidence-based strategies for VTE assessment, prevention, and management. Please join us in welcoming Dr. Brown.
Thanks, Shelley. Such a great introduction. Thank you for that. And thanks to Anne for the invite and to SVN and AVF for the opportunity. I'm going to talk today. I'll share my screen here, see if this works before I ruin this. Can you guys see that? Or at
There
least
it is.
getting there.
Mhm.
So the topic title is super general, obviously, and I know I'm talking to a group of people who pretty routinely treat this disease, so I don't want to spend too much time on the kind of the basics of it. We'll kind of quickly go over the epidemiology and risk factors and presentation and workup, that kind of stuff. We'll talk about a little bit of the nitty-gritty details there, but mostly blast through that stuff. And then I want to talk a little bit about how we think about medical management of VTE and some of the complications of venous thromboembolism. And then a little bit about operative planning and who we treat endovascularly and who we treat with anticoagulation alone. And then I want to talk a little bit about the newer evidence. So there's the latest VT guidelines are really from 2021. And so there's been quite a few developments in that space of anticoagulation and extended thromboprophylaxis that I'll talk a little bit about at the end. So I'll try not to take everybody's time. I know it's 7 o'clock for the East Coasters and probably the end of the day for even the West Coasters. So we'll try to make good time here. From an epidemiology perspective, again, not to beat a dead horse, but VTE is super common. Happens about 900,000 new cases a year, 550,000 hospitalizations, and 100,000 deaths. And the lifetime risk for people over the age of 45 is about 8%. So it's quite common, and I know you guys see that clinically. This is, I'd be remiss without putting in the Big House and touting the Michigan name. So the Big House houses over 114,000 people, and so every year that's 8 big houses full of VTEs that you guys are treating with the clinical consequences, which we'll talk about in a minute. From a healthcare expenditure perspective, it's wildly expensive. So just the direct costs alone are about $10 billion in the US. There's, kind of rough estimates for how that goes in terms of total cost for, complications, loss of work, all the kind of secondary costs that come with that. But it's probably on the order of $50 billion a year. So it's a substantial amount of money. that has been increasing too, in particular for Medicare expenditures. So this is a paper out of the Journal of the American Heart Association from 2021. And I think you can see the trajectory with the advent of DOACs and Medicare Part D spending on DOACs replacing warfarin, the costs have gotten out of control. So we're looking at just $5 billion in apixaban spending alone back in 2019. And you see the trajectory. So this is probably accounting for a massive chunk of Medicare spending now. And I think is something, sort of underscores the importance of VTE as a diagnosis and treatment. From a risk factor perspective, you guys have all heard of Virchow's triad. This guy, he's kind of interesting fella. He actually wasn't the one who first coined this term. He was a guy back in 1856 who he was a pathologist and he studied this in autopsies and sort of posited a lot of the details around. He was the first person to suggest that a pulmonary embolism could have traveled from a DVT in the leg. But he also sort of posited a lot of these concepts and the idea that the combination of circulatory stasis or static blood flow, hypercoagulability, and then endothelial injury contribute to the formation of a venous thromboembolism. Obviously bears his name now. So I'm not going to go through each and every one of these. You guys have all done a Caprini score and have understood the consequences of a lot of these risk factors clinically. But one of the things that I put all these up here, mostly just to make the point that if you look at every single one of them, they can be categorized into one of those three categories. So, inherited thrombophilia obviously is hypercoagulable, but we talk about other things like a history of VTE or malignancy or lupus, IBD. Those are all pro-inflammatory conditions that result in increased thromboembolic potential. And so you can kind of categorize these into those three categories. And if you think about it from that perspective, you don't really need to remember the exhaustive list of all the things that contribute to VTE risk. It's just the things that can affect one of those three categories. In terms of presentation, again, preaching to the choir here, you guys see these patients all the time. The difference between DVT and PE is clear. The whole point of me putting these symptoms up here really is not to teach you about them, but more to show you just how non-specific they are when you get a list of them in front of your face. So you see these things and you're like, I think I can diagnose a DVT in the clinic, right? But the reality is that the clinical diagnosis of DVT is horrible. We're really bad at it as clinicians globally. The overall sensitivity of the clinical exam alone is probably on the order of 70%. The specificity is much lower, probably a coin flip in terms of whether or not you're right about whether the patient has a DVT or not. And so it's important to have that index of suspicion because it's a thing that we don't want to miss. But the cornerstone of DVT diagnosis is obviously the imaging and the laboratory evidence. So currently, duplex ultrasonography is the gold standard for diagnosis of a deep vein thrombosis. It's not helpful from a pulmonary embolism perspective, but DVT, like I said, that is the gold standard, has a sensitivity and specificity greater than 95%. So really is the gold standard test. But we don't want to do duplexes on everybody who has a swollen leg. And so this, if you guys haven't seen the Wells criteria, if you're not using this clinically, this is the question of how do we not do duplex studies on every single person who has a swollen leg. And this evidence really goes back to Philip Wells, who published this paper back in the New England Journal in 2003. And really what they did was they calculated the score for each patient based on this set of criteria. So that's all these risk factors we've talked about: active cancer, paresis of a leg, bedridden, surgery, localized tenderness, swollen leg, calf swelling, edema, etc. And really what they found was that with the combination of a low Wells score and a negative D dimer, you can effectively rule out a DVT. And this was kind of codified back in, I think this paper was from 2021. This is Fedor Lurie, who has an appointment here at, whoops. Oh no, I'm ruining the whole talk. I'm giving it all away. Fedor Lurie is this really amazing surgeon at Toledo, and we spent a lot of time with him here up at the University of Michigan. I learned a lot from him and his role with the AVF. But basically, the premise of this paper is they took patients who had suspected lower extremity DVT and had a duplex ultrasound, and they categorized them based on their the presence or absence of a Wells score greater than 2, and then looked at the sensitivity and specificity for the combination of that plus D dimer to really get a sense of like what is the true specificity, or in this case, what we're interested in is negative predictive value. So what is, if a patient has a negative Wells score and a negative D dimer, can we rule out DVT such that they don't need a duplex? And really what they found is the answer is yes. So you can see here on this table on the right, I don't know if you guys can see my mouse or not, but the patients who had, there was, almost 2,100 patients who had a negative Wells score, so less than 2, and had a D dimer test. And of the population that had a positive D dimer but a negative Wells score, there was only 27 out of the total 2,100 patients who had that positive test, and or had a DVT in that group. And so really that translates to a 99.8% negative predictive value. And that's kind of the number we care about clinically. We talk about sensitivity, we talk about specificity, and those numbers are important. But for those of you that don't have that training, what those numbers mean is actually dependent on the baseline probability, or what we call the pretest probability for that diagnosis. So in a population of people who are actually quite unlikely to have a DVT, the negative predictive value can be a better marker for the actual utility of the test. So how does that translate to how we actually take care of patients here at the University of Michigan? This is our kind of criteria and how we use this. And this is written by Tom Wakefield, who was our section head for a long time, and so a very well-known guy. And he sort of wrote our institutional criteria in terms of how we diagnose and manage DVT, and also the textbook, turns out. So this is from their Handbook of Venous and Lymphatic Disorders. But really what it comes down to is you have to calculate the pretest clinical probability. And again, that's done with the Wells score. You can do that with other validated scoring systems, but the Wells criteria are probably the best validated so far. If the patient's low or moderate probability, then the D dimer is helpful. And so if the patient has a negative D dimer, that's it. You're done. If they have a positive D dimer, obviously they get an ultrasound. On the high probability side, though, it's a little bit tougher, because in that scenario, you might not, the addition of the test that is D dimer in terms of its negative predictive value has less of an effect due to the high pretest probability. And so in those patients, they end up getting serial ultrasounds as a way to sort of hedge against that high pretest probability. And so you can see how that translates out in terms of treatment, but that's really the way we use it at Michigan. So what about medical management? So the goals of therapy for venous thromboembolism treatment in particular are threefold. One is prevention of extension of the thrombus or recurrence of deep vein thrombosis. Two is prevention of pulmonary embolism, obviously. And the third is to minimize the late sequelae of thrombosis, and in particular, that's post-thrombotic syndrome. And it turns out that anticoagulants are quite good at accomplishing goals 1 and 2, but they're remarkably terrible at preventing the late sequelae of thrombosis. That's where these endovascular therapies and attempts to try to address the consequences of post-thrombotic syndrome can be helpful, and I'll talk about that in a minute. So anticoagulation really does work. So you can see the rates of recurrent thrombosis amongst people who get no anticoagulation are almost 50%. So very high. And the rate of pulmonary embolism is similarly very high. And that rate drops dramatically, almost a tenfold reduction in the risk of recurrent thrombosis, and an even higher drop in the risk of pulmonary embolism with appropriate anticoagulation. The baseline risk of major bleeding with most anticoagulants is probably around 3%, but that has been dropping with the advent of DOACs and I'll talk about in a while, the utility of reduced dose DOACs. And so this number is actually getting better. VTE recurrence, we know from lots of studies, is highest within the first probably 6 months. And so that's why the current recommendations are for a treatment phase of 3 months of anticoagulation. But the PATIS PE trial was this trial that came out in 2015, really looking at the effects of prolonged thromboprophylaxis, or so what they call the post-treatment phase for anticoagulation. And this gets at the question of, okay, we have a patient who has a DVT. We don't really know what their long-term risk of DVT is. We know that some patients are at an elevated risk for recurrent thrombosis or pulmonary embolism. And so in this case, the trial was around 6 months, but they randomized people who had an acute DVT and got 6 months of of treatment to either extended 18 months of ongoing anticoagulation or placebo. And you can see there was a dramatic difference in the risk of recurrent VTE in this trial, which really sort of set the stage, at least from a clinical trial perspective, that ongoing prophylaxis or treatment, really, but it's to prevent recurrent thrombosis, is super effective. And you can see the table here in terms of the individual patient benefit is dependent on their individual pretest probability of the outcome. And so for patients who had a major reversible factor, the benefit of prolonged anticoagulation is actually not as much as if they had an idiopathic DVT, or traditionally we've called this provoked or unprovoked DVTs. We kind of stopped using that language a little bit with the last iteration, but the principle is similar. So the current treatment paradigm right now for VTE is obviously an acute treatment phase. There's sort of 3-week period of run-in with a high-intensity initial treatment, usually 10 milligrams BID of apixaban or 15 BID of rivaroxaban. Then we transition that during the initial 3-month period to the standard doses of apixaban or rivaroxaban. And again, that's not the only way to treat DVT, but certainly is the preference for most people. The extended VTE prophylaxis is treatment after 3 months, and that has changed a fair bit recently. So there's a couple of trials I want to talk about that have come out in the last 12 months. In particular, this one called the COBRA trial, which was really a randomized controlled trial published in the New England Journal of Medicine, I think this year. I think it was 2026. And really, this was getting at the question of, well, which one's better, rivaroxaban, apixaban? There's a lot of discussion around, one being better in terms of the bleeding risk than the other. A lot of people look at the pharmacokinetics of apixaban versus rivaroxaban, and there's some concern that that rivaroxaban is dosed once a day, whereas apixaban is dosed twice a day. So there's periods of over anticoagulation in rivaroxaban and subtherapeutic anticoagulation versus apixaban, which a lot of people worry is more of a steady state dose. And so this clinical trial was aimed at answering the question, is there a bleeding risk difference between apixaban and rivaroxaban? It turns out that there was in this trial. So you can see here the survival curves, but there was a dramatic difference. The overall rate of clinically relevant bleeding in patients who got apixaban was 50% lower in the than rivaroxaban, and that bore out for relevant bleeding, but there was no difference in the risk of recurrent venous thromboembolism. And so this hasn't, like I said, this trial came out probably 2 months ago, but hasn't quite made its way into the guidelines yet. But I suspect there will be a push, as there already has been, towards more apixaban and less rivaroxaban as the primary DOAC of choice for VTE, at least for initial treatment. So you guys have all seen this line in the CHEST guidelines, and if you haven't, this is the guideline number 26 in the CHEST guidelines for 2021, and it recommends for patients who get offered extended phase anticoagulation. So this is, again, people who've treated their we've done 3 months of anticoagulation with some DOAC, and you're considering extended phase treatment for some period of time. Most people, that's lifelong, or at least until some reversible risk factor can be altered. The guidelines recommend, with a weak recommendation and low certainty evidence, to reduce the dose of apixaban to 2.5 milligrams twice daily, or rivaroxaban 10 milligrams once daily. So basically half the dose. But again, this is based on really poor evidence. So this trial, the HiPro trial, came out last year. And again, this has not quite made its way into the recommendations, but I suspect will result in this line basically saying the same exact recommendation, but with a strong recommendation now with randomized control trial evidence. But what they effectively were looking at was, what is the effect of reduced dose of apixaban on the extended treatment of venous thromboembolism? And what they found was that cutting the dose of apixaban in half resulted still in a substantial benefit with respect to the hazard of recurrent symptomatic VTE. That's this figure on the left. So, a 90% reduction in the risk of recurrent VTE, but almost no effect on the clinically relevant non-major bleeding. And there wasn't a single event of major bleeding for either group. So basically, apixaban resulted in a significant benefit at the reduced dose, and there was effectively no clinically relevant bleeding to being on um, the extended treatment low dose apixaban. So the way this, the way that I use this clinically is really dependent on this VTE predict score. So for you that haven't seen this, this was a collection of papers that came out. The actual prediction algorithm was published in 2023 by DeWinter, but it's a really great calculator. I use it clinically all the time. I use it for patients right in front of them. So it's really helpful to make shared decision making with patients in the office. And so this is a website. You can just type in VT predict into Google. It'll be the first thing that comes up. And really what it looks like is this. And so you go right in front of the patient, I type in all their information. The risk factors that were validated within that risk calculator are around are they on a platelet aggregator, NSAIDs, pulmonary embolism, estrogen therapy, surgery or immobilization, history of VTE, cancer, bleeding, and then BMI and systolic blood pressure along with their hemoglobin. And so not really that many things, certainly things that we have information for every single patient for the most part who's coming to your clinic to talk about VTE extended treatment. And what it does is it calculates their 5 year or 1 year, if you choose, their 5 year risk of recurrent venous thromboembolism and then clinically relevant bleeding. And so you can alter this right in front of them to illustrate the benefits to extended phase treatment versus no treatment. So I have this conversation not infrequently, as I'm sure many of you do. Patients hate being on blood thinners and they want to talk about, I bleed all the time. I want to get off this as soon as I can. And this really provides a really concrete way to show them exactly what you're talking about. So this, for example, is a set of risks that I just put in. Doesn't really matter what the risks are, but this calculates this patient's 5 year risk of recurrent venous thromboembolism at 12%. Their risk of 5 year clinically relevant bleeding is 6.8%. And I here on the right side, I have no anticoagulation. This is extended phase anticoagulation. So this assumes they've already been treated for 3 months and we're trying to make a decision about their extended phase treatment. But if I change it to full dose apixaban, as we all know, we can dramatically improve their risk of recurrent venous thromboembolism by, dropping their VTE risk over 5 years by 80%, really, with a number needed to treat of 11. But it comes with it a 4% increase in the risk of clinically relevant bleeding. Now, that's a discussion to have with a patient, but in the light of the new evidence, it turns out that reduced dose apixaban, which is all that's changed in this box over here on the right, it has the exact same reduction in recurrent risk of VTE at 5 years with a minuscule increase in their 5 year clinically relevant bleeding. And so I think this is a really nice way with patients in the clinic to just show them, hey, you can get 90% of the benefit or even 100% of the benefit in this case with really quite minimal risk to you. And I think people are much more willing to tolerate that, at least from a quality of life perspective. It still has its costs in terms of literally financial costs and things like that. So it's a separate conversation, but I think this is a really nice way to drive home the benefits of taking this medication and putting it in the context of their overall clinical picture. So anticoagulation works really well for 1 and 2. It turns out not to work very well for 3. So what do we do about post-thrombotic syndrome? So for those of you that don't know, PTS, as we call it, post-thrombotic syndrome, is really the late-term sequelae of the resolving thrombus, and that often results in trabeculations, sometimes complete occlusions, sclerosis, scarring of the vein, and it really affects the vein often in 2 ways. One is it can lead to venous obstruction that just literally prevents the flow of blood in the antegrade direction. The other is that it can lead to fibrotic or thickened valves that actually don't function, and so it can lead to reflux as well. So we see PTS in patients who have both phenotypes, and the treatment is unfortunately very dependent on their phenotype. So venous obstruction, generally we can treat with mostly endovascular techniques now, involves recanalization and stenting for the most part, and ballooning of their deep venous structures. The reflux from fibrotic valves is very difficult to treat. In those patients, there is no widely effective treatment currently. There's ongoing clinical trials for implantable artificial valves. You've heard probably about the vena valve and things like that. And so there's work ongoing in that space, but it's all still mostly preclinical at this point, and there's nothing that's widely effective or widely available for these patients. PTS is really common. It turns out like 50% of people who've had a DVT develop some degree of post-thrombotic syndrome, and 20% of patients will develop severe post-thrombotic syndrome. Leads to a huge burden financially in the US, about $7,000 per patient per year of the remainder of their life, which these patients often they don't die from this. So this is a thing that affects relatively youngish people and is a prolonged suffering over the remainder of their life. Venous ulceration alone results in 2 million lost days of work per year in the US. So it's kind of like this thing that doesn't get counted a lot in terms of secondary subsequent costs to society, but it really is quite a burden. Iliofemoral DVT is really where it's at in terms of the risk of this. So about 80% of femoral popliteal venous thromboembolism will recanalize, and the patient's probability of developing post-thrombotic syndrome is very dependent on their rate of recanalization. So reflux develops in about 80% of patients who've had an iliofemoral DVT venous claudication in 40%. So it's really common, in particular with these proximal VTEs. That rate historically was much worse. It's probably better now, and the data from there's kind of two major trials that we talk about from a post-thrombotic syndrome perspective. One called the CAVA trial, and the other is the ATTRACT trial, which is worth reading if you've never read that study. But the severe PTS rate's probably closer to 1 in 8, 1 in 6, somewhere in there. Still pretty common, but not quite like we used to think. So how do we integrate treatments at Michigan in the setting of kind of a mix of evidence? So for patients who have femoral popliteal disease, like I said, the vast majority of those patients recanalize. And so there isn't a huge role for venous thrombectomy or lytic therapy in those patients. And at least at the University of Michigan, I think most institutions are treating people this way, that if they have a femoral popliteal lesion, they just get follow up and anticoagulation as the treatment. But this is all pretty much what I said. So the problem with iliofemoral disease is we don't know who gets better. We don't know who recanalizes, and we don't have a great way to predict who's going to recanalize. So that's the crux of the issue now, and you'll see that bears out in the ATTRACT trial. So the ATTRACT trial was a randomized control trial of really lytic therapy, catheter-directed thrombolysis with or without mechanical thrombectomy techniques. They were allowed in the trial, but they weren't really the test of the trial. And what the trial showed was that globally, catheter-directed thrombolysis didn't change the rate of post-thrombotic syndrome. The difference was that in a cohort of patients who had iliofemoral DVTs alone, there was a benefit. Now, I fancy myself to be a reasonable researcher in the grand scheme of things, and I think Anne has probably heard me whine about this in the clinic. I don't really trust any non-pre-specified tiny little subgroup of a randomized control trial. I think the burden is on us to prove that this works, but certainly when surgeons have a surgical technique, they're going to use it. And so people generally look to this data as evidence for the utility of, again, catheter-directed thrombolysis, and honestly, they extrapolate it into the space for mechanical thrombectomy, despite the fact that we actually don't have great data in that space. So how to integrate the ATTRACT trial into our clinical practice is actually a very tough decision and involves a lot of debate, both at the sort of societal level and at the individual institutional level. So the big problem, I think, even if you believe this subgroup analysis, is that there wasn't a lead time where patients got anticoagulation prior to catheter-directed thrombolysis to see who was going to benefit. So, and that's, I think a lot of people would agree that, the benefit, it's not like a thing that you don't have to suction out their clot or do thrombolysis immediately unless they have phlegmasia. That's a different scenario, but the benefits long-term are probably not super time dependent. And yet we can see who is going to have improvement in their symptoms with a very relatively short period of time on anticoagulation. So the way that we've chosen to integrate that at Michigan, and I think, a fair number of people kind of go this path as well, is that if a patient is found to have a proximal DVT, and it's present in the iliofemoral segment, then we make a decision based on their severity of symptoms. So it's really hard to make people better when they're not really that symptomatic in the first place. So if they have mild symptoms, we actually discharge them straight from the ED with elevation, compression, and anticoagulation, and we have close follow-up. If those patients have moderate or severe disease, and the way that it's done at Michigan is based on the Villalta score. That's another validated venous severity score that incorporates a whole slew of symptoms. It's relatively objective. Um, that if they have moderate to severe symptoms, we admit them to our medicine service and initiate anticoagulation, and we observe them for usually about 48 hours. If patients have a substantial improvement or look like they're on a trajectory to have substantial improvement for up to 4 weeks, honestly, then we let them get better. And if they stall or they have insufficient improvement or they don't have a trajectory that's looking good, then we start to talk about this candidacy for more advanced operations. Um, there's a set of things. So I said catheter-directed thrombolysis is really where the evidence is in the setting of the ATTRACT trial. Again, they could use pharmacomechanical thrombectomy in that as an adjunct, but it wasn't really the test. And that it presents a whole nother set of problems because a lot of people, the technology around pharmacomechanical thrombectomy has changed dramatically since the ATTRACT trial was published. And for a lot of people has become the primary treatment modality, not lytics. And so, what to do about that from a data perspective, we're a little bit behind the times, but there are some well-known contraindications to lytics. Those are listed here, and I think the obvious ones are active bleeding, but there's a whole slew of other ones that you wouldn't necessarily expect. Pregnancy is a little bit of a controversial one as well. But if a patient is a reasonable candidate, then we would consider CDT or catheter-directed thrombolysis with or without pharmacomechanical thrombectomy for those patients who don't really benefit. Now, if a patient has a contraindication to lytics, then you can consider just going straight to a pharmacomechanical thrombectomy alone with anticoagulation. And again, we don't have any evidence for this. There's no great evidence to show that this is beneficial, but it's a reasonable option in the setting where we know that at least based on the ATTRACT trial, that resolving the thrombus with CDT results in a decreased rate of PTS. And so we kind of extrapolate that evidence, but it really involves a risk benefit discussion with a patient because it's not a free operation and it does have the potential for some problems. That's pretty much all I got. I would be remiss to not thank all the people on this list, most notably Andrea Obi, who I stole at least 90% of these slides from, and then the whole team here at the University of Michigan for our venous health program. We have a super collaborative group that involves interventional radiology, our vascular medicine colleagues, and then vascular surgery, obviously. And it's a really great group to be a part of. So with that, I'll take any questions if you guys have them.
Excellent, excellent. I think that was very informative and wow, I love it. So one question that just comes to mind, we'll start off with, and I know you didn't really approach this, but and sorry to maybe sway from the topic a little
You're all
bit,
right.
but how do you typically handle management of your APS patients in deciding anticoagulation and
Yeah.
how, because a lot of people are living in rural settings
Yeah.
and, maybe don't have access to some of that, yeah, those
Yeah. In terms of,
testings. Yeah,
yes, yes. Um, yeah, I think that there's a whole talk we could talk about in terms of hypercoagulable workup and the utility of that. I think in the inpatient setting, APS is one of the only ones that we test for, and that has been decreasing over time, and that really comes at the guidance of our hematology colleagues. So I think there was a randomized control trial in the New England Journal. It's probably been 15 years now, where they tested APS patients for warfarin versus other anticoagulants, and warfarin really came out as the preferred anticoagulant in APS. That trial has now been repeated and actually had differing results. And so there's now kind of two randomized control trials that have differing recommendations with respect to the effect of apixaban in particular in APS patients. So our hematologists here at the University of Michigan really have been in favor of, unless they're like we have some older hematologists that really push towards warfarin, but I think as a group, it becomes a more comprehensive discussion with the patient. Warfarin obviously has its own problems, and so how to manage warfarin in a patient who um, maybe doesn't have a great social structure for being on warfarin. They don't have access to testing. They don't have access to sufficient food resources to be able to tolerate that. I just push them towards apixaban, and I don't feel bad about it because now we have randomized controlled trial evidence showing that it's equivalent. And I think that again, that debate is more academic at this point because I think the two trials at the very least show that they're relatively comparable. And I'd much rather have a patient on something than an ineffective anything. And so I think we've sort of lowered the threshold to push people towards DOACs uh, when they have any particular reason to be off of it, off of warfarin. I mean,
Excellent. Perfect. There are some questions coming in here, and so I'll start with one here. Um, do you recommend lifelong compression following DVT?
yeah, that's a great question. Complicated question. So the evidence for compression therapy in decreasing the effects of post-thrombotic syndrome is poor. And I think that anybody who's prescribed compression therapy knows it's highly variable whether patients, well, some people love it and they wouldn't imagine ever being out of compression. Didn't matter if you told them they should be on it or they should have compression or not, they want to do it. And we have other people who absolutely hate it, kind of fall into that group myself, to be honest with you. I've tried it, hate compression. And I think the evidence is poor enough that I generally leave it up to the patients. There is reasonable evidence to show that routine compression after DVT does not decrease the risk of post-thrombotic syndrome. That doesn't mean it doesn't help symptoms, but it doesn't decrease the risk of post-thrombotic syndrome development long term. And so if you're recommending it to a patient to prevent PTS, probably not a great idea. But I mean, I've certainly had patients who think it makes subjective help, and so I definitely don't think it hurts anything. So I think if the patients try it and they prefer it, I just leave it up to them.
Excellent. So, um, practice algorithm for holding DOACs in the setting of renal impairment.
Yeah. That's a tough one. I think that's also a moving target a little bit. I usually lean on our pharmacy colleagues a little bit. The there has been some data around reduced dose apixaban for treatment phase in VTE in patients who have renal failure or renal dysfunction. I think the best evidence is in apixaban, and I think probably that's that's where I tend to go for patients with renal dysfunction if they're really insistent on a DOAC. The other option is Lovenox, but again, it has its own, you got to dose adjust for renal impairment and Lovenox as well. So um, it kind of gets to your point, Shelley, which is sometimes it's patient dependent. Really, it's about their circumstances. But I think that the risks of over treatment in patients with renal impairment are probably overblown, and we probably should err on the side of treating people with renal impairment because um, they definitely have a major benefit, and the bleeding risks in all comers is very low. And I think the effect of the renal impairment in terms of added risk of bleeding is not nearly what we think it is in terms of they still have a substantial benefit. Patients with renal failure also, it's an independent predictor of VTE in and of itself. So I think those patients probably deserve some treatment, and you just got to be thoughtful about how you integrate that with the pharmacy team. But generally, I think they should get treatment.
All right. Yeah, Anne just brings up cost plus drugs
Yeah,
online, sells Xarelto 2.5 for $20 a month. So unfortunately, they don't have Eliquis at this time.
yeah,
So yeah.
yeah. The cost of DOAX is no joke. You guys know that. You deal with that every day. I think you know. Some, like I said, some of the Cobra trial and the High Pro trial are starting to point towards there's probably a benefit to apixaban over rivaroxaban. But that being said, if there's a substantial difference in cost, that matters to me. I think you guys have talked with patients. You can talk with one person and they'll tell you that $400 a month is no big deal. And then you have a patient in the next room who says, I can't afford a $30 difference in copay. That's a catastrophic price difference. So really, you just got to talk to the individual patients and find out and just ask them point blank, is this a catastrophic expenditure? And I'm very sensitive to that personally. So I think um, I don't think that the clinical benefit of apixaban over rivaroxaban justifies a catastrophic expenditure difference to me, and I really make sure that the patients feel comfortable with the copay. I will say in patients who both of them are expensive, that's a conundrum because the clinical evidence for a DOACs over warfarin, for example, and honestly the total cost of care with warfarin, it's just so much better that I really
Mhm.
push our social work team here and push manufacturer coupons and GoodRx and all these other options because usually there's a way we can get some amount of treatment with a relatively low cost for patients. And so I think that one I push a little harder.
All right, I'm gonna try with this one here. Somebody has a question with regard to history of venous thromboembolism and then holding anticoagulation for surgeries like ortho
Yeah,
and or
yeah.
colonoscopies and dental work. And so, yeah.
Yeah, I think for people who so the you're talking about like I'm gonna maybe two questions there.
Yeah,
Bridging versus
yeah,
not bridging, and then
correct.
holding it and whether it's okay to hold it. I think globally, when you're talking about a patient with a history of VTE who's not on treatment phase, so they've extended past the 3 months of initial treatment, and we're talking about their extended phase treatment to prevent recurrent venous thromboembolism, that's a risk over the course of five. You saw the VT predict score. Like even a patient who has a lot of risk factors has a 5 year risk that's somewhere between 10 and 25%. So that's over 5 years. So if you hold it for a week, I mean, we're talking about a minuscule individual week risk of VTE, and it's absolutely reasonable to do that, especially if it's going to result in any meaningful increase in their risk of bleeding from the procedure, which could be catastrophic. So generally, I'm very liberal about that. In terms of bridging or not, that's a tough one. Uh, for the most part, there's a randomized control trial in the New England Journal of Medicine called the Bridge Trial for AFib, which that really the evidence around that is related to whether or not there's an active clot or not. So patients who have an active clot that you're treating in the treatment phase within 3 months, that risk is pretty high, whether it's AFib and they have an atrial thrombus or whether they have an acute DVT. But if they're outside that, then they don't need to be bridged, generally speaking. So I think you can make that decision with each patient. But again, general guidance is if they're in the treatment phase, probably should be bridged. If they're not in the treatment phase, they don't need to be bridged.
Okay, that's excellent. Excellent. Any other questions coming in from the people online still? Not seeing anything else coming in. So, with that, any other comments or questions? Okay. Well, I think we can probably sum things up here and let everybody get on to their rest of their workday.
Perfect.
And it's been an thank you so much. I've learned quite a bit listening to your discussion. And here come the thank yous.
Yeah, great. I'm
I
happy
think
to be here,
every
guys. Thank you.
awesome. Well, we appreciate your time and your willingness to share your knowledge with us. So you all have a good night.